Our next speaker is Dr. Marie-France Hivert. Dr. Hivert is an associate professor in the Department of Population Medicine at Harvard Medical School. She's a clinical investigator with primary focus on the etiology and primordial prevention of obesity and related comorbidities, particularly type 2 diabetes and gestational diabetes. Her interests also include fetal metabolic programming mechanisms and the integration of genetics, epigenetics, and environmental factors contributing to obesity and related disorders. The title of her presentation is Precision Approach to Diabetes and Pregnancy. And Dr. Hivert is with us live. Great to have you.
Thank you very much for this kind introduction. Everyone can see my screen?
Yes.
Yes, we can.
Yes.
So I would like to thank the organizing committee for inviting me to talk today. It's a real pleasure to be here. In the next few minutes, I'll try to give an overview of gaps and opportunities for precision medicine in the field of gestational diabetes. I firmly believe that precision medicine has so many opportunities to improve the care of women affected by gestational diabetes and their offspring. During this presentation, I'll touch on all 4 pillars of precision medicine as outlined in the first consensus report, but by no means I'll be able to go in details in any particular one. Starting with the current definition of gestational diabetes, for many years, the classic definition has been any degree of glucose intolerance that was first recognized during pregnancy. Most recently, the ADA proposed the following definition, which is diabetes diagnosed in the 2nd or 3rd trimester of pregnancy that was not clearly overt diabetes prior to gestation. And this is mainly with that definition in mind that I will talk today. But this updated definition did open a very key question on how to define hyperglycemia detected in the 1st trimester that is not clearly overt diabetes. And I think that is one of the gap in area for future opportunities in the field. In most countries, the current recommendations are to do universal screening between 24 to 28 weeks of gestation using an oral glucose challenge, using either a 1-step or a 2-step approach. And there's still a lot of controversies about what is the best approach, but as many of my colleagues suggest, maybe instead of arguing between a 1-step or 2-step, we could find better diagnostic tools to screen and diagnose gestational diabetes. Diving into precision diagnostics, one of the key questions that the field has is, can we predict who will develop GDM in early pregnancy or even before? Accurate GDM prediction could allow us to better target our screening, maybe reducing the number of women who would need to do a full oral glucose tolerance testing, or targeting very high-risk women for preventative interventions. Many algorithms have proposed a combination of known clinical risk factors or the use of biomarkers, listing just a few ones, including more novel omics biomarkers, and combining them with clinical risk factors. Many of us are also collaborating to help identify genetic markers that would be specific to gestational diabetes. This is one example of an algorithm that combines clinical factors and biomarkers, most of them already being measured clinically in standard OB practices, as listed here on the left. You can see here that all models are offering a very good prediction as reflected by an area under the curve between 0.88 and 0.91. Here is another example of an algorithm using data available in electronic medical records. In this example, the baseline model used NIH risk factors and standard regression modeling, while the current model in light blue use a much larger sets of variables, all available in EMR, and apply machine learning techniques to develop the predicting model, again, with a very decent area under the curve of 0.5. But as we all know, quite often these prediction models perform very well in the source population or in very similar population, but not as well when tested in other settings or other populations. We hope that one of the downstream impact of the next PMDI consensus report will invite collaboration between diverse groups from different countries to improve our prediction models and progress towards clinical applications around the world. On the genetic side, we can say that genetics of GDM per se still is in infancy. Most attempts at GWAS have been underpowered and reverted to test whether the known loci for type 2 diabetes are also associated with gestational diabetes. This is one GWAS that was published almost a decade ago, still one of the best powered published so far. They identified 2 loci that were already known for risk of type 2 diabetes, including the melatonin receptor 1b, which I want to point out here had a much greater effect size per risk allele on the risk of GDM that it would be anticipated for its risk on type 2 diabetes in the similar population. Luckily, the field of genetics of GDM is also a very collaborative one, and this is unpublished results from the GenDib consortium. Again, despite trying to rally pretty much everybody we know, our sample size is quite modest with slightly more than 5,000 GDM cases. And you can recognize here many of our favorite loci for type 2 diabetes. I want to point out again the confirmation of the very strong effect size for the melatonin receptor 1b. But I also want to point out that we identify one gene that seems to be specific to pregnancy status, and it's HKDC1 that we had previously identified as being associated with maternal 2-hour glucose in meta-analysis, including HAPO participants and Gen3G. And despite our modest sample size, we had a very convincing p-value. So I want to point out that there are probably loci that are specific to pregnancy, but we will still need to increase our sample size to discover more unique loci. But there's still a lot to be done in this field. Continuing with our opportunities in precision diagnostic, I'd like to share with you a few recent publications that have opened up the field of subclassification of GDM per se. The next few studies that I will present are based on analysis conducted on data collected in a prospective pre-birth cohort called Gen3G that I have the chance to lead with colleagues from Canada. In between the years of 2010 to 2013, we recruited over 1,000 pregnant women during their first trimester. We followed them up between 24 to 28 weeks of gestation, where they all completed an oral glucose tolerance test. And based on that, we know that about 8.4% of women develop GDM, which is expected in this mostly European descent cohort. But we also measure insulin and glucose at multiple time points during this OGTT to estimate insulin sensitivity and insulin secretion indices, in addition to multiple other biomarkers. We followed up women at delivery, where we collected clinical outcomes in cord blood and placenta samples in over 700 of them. One of our key investigations looking at in heterogeneity of GDM was led by Dr. Po, and she nicely presented in our workshop this morning. But for those of you who weren't here, let me summarize the results. After calculating the insulin sensitivity and insulin secretion indices, we can plot them along those two axes to represent the continuous disposition index. And we then categorize gestational diabetes according to the predominant physiologic defect driving the pathophysiology. So we categorize women with GDM to have a sensitivity defect if their Matsuda index was below the 25th percentile of the normal glycemic distribution, and about 50% of our women with GDM had this predominant defect. Then if women had predominantly insulin secretion defect, meaning their insulin secretion was lower than the 25th percentile of the normal glycemic distribution, we classify them as having insulin secretion defect gestational diabetes. And then if they had both a low Matsuda and a low insulin secretion, we categorize them as having a mixed defect. More recently, Dr. Po and Dr. Adler collaborated to apply a soft clustering approach that I'm sure Dr. Hodler will speak of in her talk. And just to summarize here, they use over 200 known type 2 diabetes loci and over 35 pregnancy traits to derive pregnancy-specific cluster of a genetic risk score. And by building polygenic risk score based on those cluster, they identify a first pregnancy-specific cluster that was associated with a greater risk of developing GDM in 2 independent cohorts, including HAPO participant and MGH cohort. And this with a much stronger odds ratio than for type 2 diabetes using the same polygenic risk score in Partners Biobank participant. But why would subclassification of GDM be clinically important? Well, first, we all know that GDM is associated with pregnancy complication as the one listed here and have important consequences for both the mother and the offspring. So looking at our subgroups of gestational diabetes categorized by their insulin sensitivity or insulin secretion defect, we found that women with gestational diabetes with a predominantly insulin sensitivity defect were at higher risk of classic complication at delivery, with significantly higher rate of large for gestational age, neonatal hypoglycemia, and C-section, for an overall 3 times greater higher risk of having at least one of those classic GDM complication. And this is despite receiving the same care and targeting the same glycemic targets than the other subgroups of gestational diabetes. Presence of gestational diabetes also been associated with long-term outcomes, and women affected by GDM are more likely to develop type 2 diabetes and cardiovascular disease over their lifetime. In offspring exposed in utero, observational studies have shown they're more likely to have excess adiposity and impaired glucose tolerance. But why should we improve precision prognostic for future type 2 diabetes in women with prior GDM? Well, this risk is definitely not trivial. Up to 50 to 60% of women will develop type 2 diabetes over their lifetime. And you can see that's a strong enough risk factor of itself, but you could also say, well, 50% is not much better than the flip of a coin. So wouldn't it be nice to know a little better who is really likely to develop type 2 diabetes? Recommendation from American Diabetes is to screen a woman with prior GDM at 4 to 12 weeks after delivery using an OGTT. But unfortunately, this is done in not as much as it should be, and often in less than 50% of women because the OGTT is so cumbersome. Again, wouldn't it be nice to know exactly who we should target and focus our effort for these postpartum screening? And finally, we know that we can prevent type 2 diabetes in women with prior GDM, and the DPP and many other trials have shown that lifestyle or metformin can reduce the incidence of type 2 diabetes by 35 to 40%, even 10 years after the lifestyle intervention. But again, it would be great to know which women we should really focus our intervention, especially for lifestyle intervention that are so resource intensive. This is one recent study that tried to have a better prediction model for women with prior GDM towards progression of type 2 diabetes using metabolomics to predict which women will develop type 2 diabetes. And you can see here that the values of the area under the curve for predicting incidence of type 2 diabetes were not bad for using only fasting glucose or 2-hour glucose, but still not as convincing as the predicting model using metabolomic signature that they derive with an area under the curve of 0.88. Once again, this algorithm is been applied to only one population and needs independent replication. For offspring exposed to gestational diabetes, my research group and many others have been investigating how the epigenome, mainly DNA methylation markers, may reflect exposure to maternal hyperglycemia, and also predict the long-term programming of obesity and diabetes over their life course. Hopefully, we can soon report exciting findings and reliable predicting epigenetic markers for this risk of future disease in the hope to stop this vicious cycle of obesity and diabetes. Finally, precision therapeutics could also be applied to gestational diabetes. Many lifestyle interventions have attempted to reduce the incidence of GDM with so far inconsistent result as presented by Dr. Vesco in our workshop this morning in the GDM session. But as many colleagues have said, many are lacking the tools to select the women that are at higher risk of GDM using predicting algorithm as presented earlier. Or maybe we need to figure out what type of lifestyle intervention works in which woman. For precision treatment, we could definitely optimize our therapy to reduce complication and maybe limit the burden of current treatment approaches as elegantly presented by Dr. Reynolds this morning. Just to summarize, currently the standard of care for gestational diabetes have clearly demonstrated that treatment can reduce complications such as preeclampsia, macrosomia, and birth injury. But current treatment standards include monitoring with testing times a day, dietary adjustment and other lifestyle intervention, mostly looking at trial and error. And if that doesn't work, then we add pharmacologic treatment, most often insulin as first-line therapy. First thing I want to point out is that we're aiming for the same glycemic targets for all women, no matter what. Some groups are using imaging, mostly looking at abdominal circumference of the fetus to decide on targeting lower glycemic targets, a positive step towards precision treatment. About the lifestyle treatment, current dietary advices are generic, mostly based on trial and error approaches, opening the door wide to potential precision nutrition. And I know that some trials are currently in the planning or in the early phases. And about the pharmacological approach, we agree that insulin should be the first-line therapy, but we also acknowledge that oral agents can be considered. But we're lacking currently the exact knowledge of how to consider the true balance of risk and benefits for an individual woman classify with GDM. So overall, I hope I was able to demonstrate that there are many potential avenues and exciting perspective for precision medicine in GDM. Using precise algorithm to predict GDM itself and the risk of type 2 diabetes with women with prior GDM. Refining definitions of GDM for better diagnostics and prognostics. I also believe that given the current major gap of how to define GDM in the first trimester, we should embrace this opportunity to go beyond glycemic threshold and use the tools of precision medicine to offer a definition that would really advance the field. The field of precision prevention and treatment is currently wide open, and both clinicians and pregnant women would welcome better targeted approaches. And finally, we're still in the infancy of precision prognostic for long-term outcomes in offspring, with the hope to offer preventative intervention in children that would benefit the most and support healthier trajectories for future generation. Before I end, I want to highlight the current members of the GDM working groups that will be contributing to the next PMDI consensus report. Also want to acknowledge my research team, both in Canada, in Boston, and all over the world, the multiple collaborators and colleagues that are part of consortia that makes a lot of our research possible. And of course, I want to acknowledge the funding agency, especially the American Diabetes Association. And I'm happy to take one or two questions now or to wait until the panel discussion, depending on the moderator.
Well, thank you so much for that really wonderful and enlightening talk. Since we're a little behind in time, if it's okay, I think what we'll do is save some questions for the panel discussion and turn to Dr. Udler.